Hello, welcome to this presentation by FERNE, the Foundation for the Education and Research in Neurological Emergencies. This educational lecture is titled The Evaluation of Emergency Department Dizziness Patients, New Concepts. My name is Edward Sloan. I am currently Medical Director of the Physician Assistant Studies Program at Dominican University. I have most recently been an attending physician at Carle Foundation Hospital, and I am Professor Emeritus in the Department of Emergency Medicine at the University of Illinois at Chicago. Support for the development of this lecture was provided by EB Medicine. I am currently President and Board Chair of FERNE. The content for this lecture comes in large part by the monograph titled The Timing and Triggers Approach to the Patient with Acute Dizziness by Jonathan Edlow. It was published in Emergency Medicine Practice by EB Medicine, December 2019. Other parts of this educational lecture and the complete lecture are available at the fern.org website or on our YouTube fern.org channel. Also available is the June 2020 podcast, which was presented to participants in 46 countries, as well as a CME option on the EB Medicine website at ebmedicine.net, as well as at the specific website address noted below. Please note the disclaimer listed below. In general, this information is intended to augment and not replace the clinical judgment that guides the management of any individual patient. What are the dizziness patient risk management pitfalls? There are several pitfalls listed in this monograph. Let me go through some of them. Number one, I thought that because the dizziness got worse with head movement, it had to be peripheral. That's not true. Dizziness that's worse with head movement can be both central and peripheral. Number two, the negative CT ruled out a stroke. We know that that's not the case. The posterior portion of the brain is inadequately diagnosed with the non-contrast CT. In fact, if you're specifically looking at cerebellar findings, you have to request thin cuts of the posterior circulation or posterior cerebellum because normal cuts at 1 centimeter can miss a small posterior circulation stroke. But in general, negative CT, non-contrast, does not rule out a stroke. Number three, I ruled out a posterior circulation TIA because isolated dizziness is never due to ischemia. Other brainstem findings will always be present. This is a misconception. You can have isolated dizziness in the setting of a posterior circulation TIA. Number four, the patient had acute dizziness for 24 hours. The neuroradiologist read the MRI with DWI images as negative, so there's no way this is a stroke. We know this isn't the case. Early on in stroke, up to 72 hours, DWI MRI can miss posterior circulation stroke. Number five, the patient had a bad headache and said he had some transient double vision, but the Dix-Hallpike was positive. Therefore, I gave him meclizine for his BPPV. You can't do that. Double vision is problematic, as is headache. These suggest posterior circulation stroke. Number six, the patient had both hearing loss and dizziness, so it had to be a peripheral problem, right? Well, remember, hearing loss can occur in the setting of posterior circulation ischemia, and you need to be careful to rule out a posterior circulation stroke. Number seven is my favorite. The patient was only 32 years old with no vascular risk factors, so there's no way that this is a stroke or posterior circulation event. Recall I mentioned colleagues have seen patients who are young who end up having posterior circulation events within a short period of time following admission for dizziness of concern. So young age does not exclude a posterior circulation etiology. Number eight, the patient felt very dizzy on gait examination but had no nystagmus at all, so I ruled out cerebellar stroke. Remember, only half of patients with cerebellar stroke will have nystagmus, and so you cannot say that it wasn't a posterior circulation stroke due to the absence of nystagmus in the presence of dizziness. Number nine, I know HINS testing, the HIT test, was unequivocally positive. I saw a corrective saccade, so the problem must be vestibular neuritis. Remember, you need to have 5 findings be correct or negative for posterior stroke on the HINTS test in order for you to be able to say it's not a posterior stroke. The presence of a positive saccade or a positive test, which is good, which suggests peripheral etiology, in the absence of the other 4 HINTS test findings suggesting no posterior circulation event, they also must be negative or suggestive of a peripheral etiology or not suggestive of a posterior circulation central etiology. And last, the HINTS testing was worrisome, but the neurologist said to do an MRI, and if it was negative, to discharge the patient. He would see him on Monday. Here's what's important. Neurologists will often suggest that you do an MRI, and if the MRI is negative for any significant finding, that you can send the patient home. Remember, the problem is that if you have a worrisome HINTS test, if any of those 5 suggest a possible central etiology, you need to observe those patients for 24 to 40 hours because signs of a posterior or cerebellar or posterior circulation stroke can manifest themselves within hours after the presentation with an acute vestibular syndrome. You cannot, in the presence of a worrisome HINTS test, any of those 5 suggesting central, you cannot send the patient home just on the basis of a negative MRI. Let's go to our dizzy patient case study outcomes. These are good outcomes. Our first case, a 44-year-old dizzy male. He presented previously healthy 6 hours of continuous dizziness, unsteadiness, feeling like he's drunk, normal vitals, left beating nystagmus with gaze, and you were told if the CT is negative, you can send him home. Wait! If the CT is okay, home with meclizine. Remember, a negative brain CT does not reliably exclude a posterior circulation event. Acute vestibular syndrome, you need to do the 5-step HINTS exam and have all 5 of those suggest a peripheral etiology. If it's a worrisome presentation that the guy says, I'm walking like I'm drunk, I can't stand up, something's wrong, that worrisome presentation requires admission for observation. What about the lightheaded 70-year-old? 70-year-old female, lightheaded for 5 days, worse with getting out of bed. The dizziness wakes her out of sleep. Stop right there. High likelihood ratio for BPPV. Hypertension and cholesterol meds. Vital signs okay, normal neural exam, no nystagmus. Should a CT be ordered and why? Now honestly, if you're considering some sinister etiology and you feel you must do a non-contrast CT, go ahead. But remember, because this is likely BPPV with intermittent dizziness, dizziness that wakes her up out of her sleep, symptoms at rest, no nystagmus, vertigo is not necessarily always reported. In this case, the best test is a Dix-Hallpike test. If it's positive, you can treat with the Epley maneuver and or the normal treatments for BPPV. What about our syncopal 58-year-old? 58-year-old diabetic, nausea, vomiting, ×3. Syncope reported, but he actually said it was really just bad vertigo and he had to lower himself to the ground. This began 3 hours previously and was sudden. He had nystagmus to the right and higher amplitude with looking to the right. The HIT test was positive, which is good. Skew was negative. He had an okay gait. Should you call the stroke team? So here's the answer. Remember, with acute vestibular syndrome, you have to have a good exam and you must answer all 5 questions to say it suggests no central etiology. So, you had some nystagmus with gaze to the right, that's okay. No skew deviation, that's okay. A corrective HIT saccade on one side, that's good. It's positive, but it suggests a peripheral etiology. No other neuro findings. His gait was normal and no ataxia. All of this is reassuring. It's less likely a presentation of posterior stroke. You can treat this patient with steroids and antihistamines. In conclusion, the ATTEST system for the evaluation of the dizzy patient includes the following. A, associated symptoms. T, timing and triggers. ES, examination signs. And T, confirmatory testing. ATTEST. When evaluating an ED patient with dizziness, please consider the following. Using the ATTEST system for evaluating ED dizzy patients, those patients with acute, severe, continuous symptoms should be considered to have acute vestibular syndrome. Patients who have intermittent symptoms or non-continuous symptoms at the time of evaluation are noted to either have triggered or spontaneous episodes of dizziness and vertigo. Topping the list of diagnoses using the ATTEST system are orthostasis, BPPV or benign paroxysmal positional vertigo, and posterior stroke. BPPV can be diagnosed with the Dix-Hallpike maneuver and can be treated with the Epley maneuver either in the emergency department or in follow-up. It is noted that you should evaluate patients with caution in the setting of the COVID-19 pandemic, as the COVID virus can cause neurological symptoms and/or can complicate those neurological symptoms because of poor PO intake and dehydration, which can cause orthostasis. Electronic medical record templates and dot phrases can help to make the exam process more systematic and easily accomplished using the ATTEST system. When evaluating dizziness patients in the emergency department, the following is recommended. Understand that the dizziness pathologies using the ATTEST system fall into 3 diagnostic strata and basically involve 6 diagnoses and 3 specific treatments for those diagnoses. Also recommended is that you study the Nystagmus findings, significance, and BPPV maneuvers, Hallpike and Epley, online and in the monograph from which this lecture was obtained. Also, create EMR templates and dot phrases to exclude posterior stroke findings in your dizzy patients in the emergency department. Explain the etiology of the dizziness, including the diagnosis and treatment, and provide appropriate referral for patients with dizziness, explaining to them symptoms which should cause them to come back to the emergency department for repeat evaluation. Lastly, utilize caution when evaluating dizziness patients in the emergency department in the setting of COVID-19, as this virus has both neurological complications and symptoms and can cause orthostasis due to decreased PO intake. If you have specific questions related to this educational content, please send an email to fern.org@gmail.com. We encourage you to go to the fern.org website for more content related to this educational program and other content related to the care of patients who present to the emergency department with acute illness and injury related to neurological emergencies. Thank you for your participation in this FERNE educational program.